Thank you to the selection committee to have another opportunity to share our research. Dr. Pauli has the following disclosures. The other authors have no disclosures to make. So non-acute full-thickness GI defects represent challenging management decisions as they come accompanied with significant morbidity and even mortality in these patient populations. Currently, the standard treatment is surgical. However, that treatment does come with significant morbidity associated with it. Endoscopic management of these defects is possible using the same surgical principles of drainage, washout, and source control. We have previously reported our results with one endoscopic method of closing these defects, the over-the-scope clip, in the management of these non-acute full-thickness GI defects. And the purpose of this study was to update our previous experience with more patients and longer-term post-endoscopy follow-up. Of note, case series investigating the use of over-the-scope clipping to date have largely been case series of 30 or less patients, with one significant exception. And that's the largest case series to date that included 108 fistulae and 27 leaks. In that study, they reported a long-term success rate of 42.9% for fistulae and 73% for leaks. They had a median follow-up of 4.8 months. Our institution has previously presented at a prior SAGES conference our experience with 22 fistulae and 6 leaks in 22 patients. In that study, we reported a long-term success rate of 76% for fistula and 100% for leaks. We had a median follow-up of 4.7 months. So for this update, it was a retrospective case series spanning from 2013 to 2019. We included all attempted over-the-scope clip closures of non-acute full-thickness GI defects at a single institution performed by an endoscopic surgeon. We excluded any acute perforations that were managed immediately at the time of perforation, and we also excluded any defects that required endoscopic suturing. Our primary outcome was long-term closure rate, which we defined as clinical or radiographic evidence of complete closure at the end of follow-up. In these endoscopic procedures, we were careful to utilize good surgical principles, as previously discussed, and employed several different endoscopic adjuncts in addition to the over-the-scope clip. Here, we are using an anchor grasper to retrieve a foreign body of a pill fragment from an abscess cavity. We attempted ablation of all GI tracts as permitted by their by all defects as permitted by their proximity to other parts of the GI tract using argon plasma coagulation. In cases where the mucosal edges were thickened or friable, we would use an anchor grasper to appropriately pull the mucosal edges up into the endoscopic cap. As shown in the last video, when the drains were malpositioned, we would adjust them endoscopically and confirm placement with fluoroscopy. And finally, as contamination is encountered, it would be thoroughly washed out. So ultimately, we had a total of 92 patients with 117 non-acute full-thickness GI defects, consisting of 65 fistulae and 52 leaks. Mean age was 54.6 years. Patients were 87% Caucasian and 64% female, with a mean BMI of 30.7. Our median follow-up time was 5.3 months. It's also worth noting that the majority of these patients presented with a single GI defect. However, a not significant proportion also had multiple GI defects. So we first compared patient demographics and patient characteristics after stratifying for long-term success and failure. We noted that history of prior radiation treatment at the defect site was more common in the failure group. However, this result should be interpreted with caution, as we also noted that our fistula group more commonly had a history of radiation exposure and ultimately had a lower closure rate. We also noted that patients with a history of prior smoking were more common in the failure group. There were no other statistically significant differences in demographics and patient characteristics. We then looked at defect characteristics. It was noted that fistulae had a significantly lower long-term success rate of 55% compared to 79.6% in leaks. We also noted that fistulae were more likely to ultimately undergo definitive operative repair compared to leaks. And then we compared the long-term success and failure in these GI defects. And the only difference that we noted is that ultimately those that failed therapy underwent more procedures in total on average. It's worth noting from these results that when we looked at all patients referred to our endoscopy service for management of these non-acute full-thickness GI defects, only 11% ultimately underwent definitive surgical management. When we focus on patients that failed endoscopic management, only 35% of those failures underwent ultimate definitive surgical management. To us, this indicates that these patients were non-operative candidates to begin with, and that this procedure was ultimately a salvage therapy in these cases. Finally, we looked at the 150 procedures that were utilized to manage these defects and stratified them by success and failure. The only statistically significant difference that we noticed was that adjustment of existing percutaneous drains was more common in our success group compared to the failure group. Finally, again, want to reiterate the importance of utilizing appropriate surgical principles in this endoscopic management of these defects. This is from the first video of this session that Dr. Witt presented, where careful flushing of the abscess cavity ultimately led to the identification of a diminutive leak, as demonstrated here on the right. In summary, over-the-scope clipping of these full-thickness, non-acute full-thickness GI defects is a safe alternative to potentially morbid surgical interventions. As I've already stressed, we had a low rate of definitive surgical repair with no urgent procedures. This is one of the largest case series to date for non-acute full-thickness GI defects. In particular for leaks, it is the largest case series to date for leaks, and we have longer-term follow-up. We noted that our fistula closure rate was higher than in other series, and we attribute that to careful attention to the surgical principles already discussed. And finally, we believe that further study to identify predictors of long-term success is necessary, and also to use that to improve on our long-term success. Thank you for your attention. I welcome any questions at this time.